Welcome and thank you for joining us today for the SEER MHOS Data Resource webinar. My name is Bryce Geiling and I'll be your WebEx host. Before I turn today's presentation over to our moderator, I'd like to share a few housekeeping items. All attendees have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation in the Q&A or chat panel and select all panelists from the dropdown. We will ask them on your behalf during the Q&A portion of the webinar. If you require closed captioning, please refer to the link posted in the chat box or the media viewer panel. And lastly, this webinar is being recorded and will be posted to the HDRP website at a later date. Now I'd like to turn it over to Dr. Roxanne Jensen.
Great. Thank you so much, Bryce. And welcome, everyone. I'm Roxanne Jensen. I'm the scientific lead for the SEER MHOS data resource and a program director in the Outcomes Research branch here at NCI. And my apologies, my camera isn't working. I normally do like to have it on when I talk to you guys. We have a very exciting webinar for you here today. I'm here with 3 SEER MHOS experts, or as I like to call them, super users. Each here is representing different expertise, research interests, and have worked with this data at different points in their own careers. So there's a little something for everyone. Each of our presenters have done very innovative work that's slightly different in using the SEER MHOS data resource. And their work has resulted in multiple published SEER MHOS papers. So the goal of this webinar is to provide information and some wisdom to researchers who are at any point in their SEER MHOS project development, from just a basic idea or an interest in this topic area to submitting your DOA, or even kind of in the process of doing your own analysis or developing and trying to get a manuscript published. So today I will start with an overview, a brief overview of the SEER MHOS data resource. And then each of our SEER MHOS experts will provide an overview of some of their work and tips they have. And then we will end with a lively panel discussion. All right. So SEER MHOS is a data research focused on measuring cancer health outcomes. It has been available for use by investigators for over 10 years. And investigators are required to submit an application that's reviewed and then sign a data use agreement prior to doing their own studies. The linkage is updated every 2 years, and the next linkage is due out at the end of this month, October 2021, which will provide cancer diagnosis data to 2017 and survey data through 2019. So the first piece I'd like to highlight is the SEER Cancer Registry data. This is a comprehensive population-based network of state and local cancer registries across the United States. It was started in 1973, and it's grown and expanded over time, and now covers over 35% of the US population. And some of the variables that we use from the SEER Cancer Registry data in SEER MHOS projects include tumor site, cancer stage of diagnosis, date of diagnosis, and vital status. Okay. And now what's new for 2021 is that we have 3 new cancer registries: Idaho, Massachusetts, and New York. And these registries are giving us data back to 2000. And so this is a huge number of cases that will be added in our upcoming linkage, and it's exciting for projects working with the SEER MHOS data resource. Up next is Medicare Advantage enrollment data. This is Medicare beneficiaries, especially those enrolled in Medicare Advantage. Medicare provides insurance coverage for about 60 million people. These enrollees are typically 65 and older, younger people with disabilities, or people with end-stage renal disease. Medicare Advantage is offered by private insurance companies approved by Medicare. Medicare Advantage consists of managed care plans, which pay per enrollee versus fee for service. And this distinction is very important because that means that there are no Medicare claims available for this data resource. And currently, as of 2021, there are over 26 million enrollees, and 42% of all Medicare beneficiaries are enrolled in Medicare Advantage. Okay. Surveys, Medicare Health Outcome Survey is a survey of Medicare beneficiaries enrolled in Medicare Advantage. All managed care plans with over 500 enrollees participate. There's a random sample within each plan. The baseline survey is administered by mail or phone, and there's a 2-year follow-up of the same participants. And the response rate is decent. It's 63 for baseline and a very robust 90% follow-up rate. Now, the kind of topics on the survey include health-related quality of life, that includes physical and mental health, symptoms and function, this can include things like pain interference, depression, and activities of daily living, effectiveness of care, fall risk management, urinary incontinence are examples of indicators that are available to the survey, and also behavioral and clinical history, self-reported smoking status and history, self-reported comorbidities. These are some of the other information available on the SEER-MHOS survey. We also have recently added Part D Medicare claims, and this covers most oral chemotherapies, supportive care medications, and medication for the management of acute and chronic conditions. Okay, before I turn it over, I'd like to show you some recent updated data for our resource and can give you a general overview of how this data is structured. This is an example of 4 cancers linked in SEER, SEER-MHOS, and you can see, for example, breast, colorectal, lung, and prostate cancer. These are the total number of linked patients, total. And then there's 3 different categories, and this is how you can think of SEER-MHOS on a very broad level. There are people that did a survey before they got a cancer diagnosis and nothing after. And you can see the numbers here range from 32% for prostate and lung cancer. It's 80% of those identified in the resource. There's this middle group where someone did a SEER-MHOS survey, was diagnosed within the 2-year window before their follow-up survey with cancer and completed a follow-up survey. And so you can see that about 7% of each of these cancers has that data available. And finally, you can see that there's a good number of people represented in surveys after cancer diagnosis. And you can see that prostate, breast, and colorectal have numbers over 50%. Lung cancer is much less. And that has to do with the length of time after a cancer diagnosis. Someone would be 65 and older and eligible to fill out a survey. And so this makes sense. All right, so I'm just gonna wrap up with some general strengths of the SEER-MHOS. It's publicly accessible. It's a large sample size from many cancer sites. One of the largest data resources on patient-reported outcomes among cancer patients in the US. It has the ability to look at change over a 2-year period and can compare people with and without cancer. So limitations are that there's no data on fee-for-service Medicare beneficiaries. Only claims data are Medicare Part D prescription drug. Sample size can be limited, especially in rare cancers. And the survey sampling frame is not designed around time since diagnosis. So you have to be very thoughtful about the timing of the survey and the cancer diagnosis. Okay, and I'm just gonna have these here, some helpful resources. We have a page you can link to go test out a sample size estimation to see if your idea has enough people. There's a listing of DOAs that have been approved that you can take a look at. And then also we have our resource publications for SEER-MHOS published papers. Okay, and with that, I will turn it over to Dr. Laura Pinheiro.
Hi, my name is Laura Pinheiro. I'm an assistant professor in the Division of General Internal Medicine at Weill Cornell. Today I'm going to be talking to you about a study that I did actually when I was a PhD student at UNC Chapel Hill. And the goal today, or my goal today, is to really share how I came up with this research question as a PhD student, how I work through conducting the analyses, and give you some tips and suggestions for using this data source when you are, a student or a postdoc, which is a little bit different than, when you're a faculty member, a lot of limited resources, time. So just keep that in mind, and I'm happy to answer any questions related to that at the end. So this study looked at the prognostic value of health-related quality of life on survival among older Americans with lung cancer. So to give you a brief background, lung cancer is the most common cancer in the world, and the 1 in 5 year survival rates are pretty poor, as you can see here. And this is a type of cancer that is associated with a high symptom burden, and this can have negative impacts on health-related quality of life. So what do I mean when I say health-related quality of life? So this is a subjective sense of well-being in response to a major illness, and it includes things like spiritual, functional, emotional, physical, and social well-being. So it's really a multidimensional construct. And there can be quality of life decrements that patients experience before they're diagnosed, which leads them to get diagnosed. It can happen during their treatments and after their treatments or during adjuvant cancer care. And for lung cancer, especially, poor quality of life can actually exacerbate some of the treatment-related symptoms. So we really care about this a lot. So what do we know about quality of life in lung cancer? So it's actually been shown to be more predictive of overall survival than an individual's performance status, which is often what a clinician may use to assess the patient's overall well-being. And post-diagnosis quality of life has been studied before and shown to have strong associations with overall survival. But when I did this study, there were no studies that had examined the associations between quality of life captured before cancer diagnosis and how well a patient does. And the interest in this is really that if you capture quality of life after a diagnosis, it could be really confounded both by the stress of the cancer diagnosis, the treatments that they're receiving, changes in behavior. And so the pre-diagnosis is really this, hopefully unconfounded assessment of the person's overall well-being. So the study objective was to determine if quality of life reported before cancer diagnosis is prognostic for overall survival. And we also wanted to see how the relationship between quality of life and survival varied by the domain. So whether we're looking at physical quality of life and mental well-being, as well as the type of measure that we use. So something that has several questions or just one single item. These are, a little bit more in the psychometric-y nerd vein here. So of course we use Serum HOS, the topic of this webinar. We included just under 3,000 individuals who are 65 years and older who were diagnosed with incident lung cancer between 1998 and 2011. And all of these individuals had completed a quality of life assessment before their cancer diagnosis. And that assessment had occurred within 2 years of diagnosis. So we wanted to capture, relatively the same period of time for all of the individuals. And this goes back to the point that Roxanne was saying, how the surveys are not administered based on diagnosis. And so it is important to be thoughtful of that piece. So we used a variety of different quality of life measures here. So first was the SF-36, which has 36 items and looks at both physical and mental components of quality of life. And I've listed the specific domains here. In the paper, it goes into more detail, about how each of the domains behaved. We also looked at activities of daily living, which are especially important for an older group of adults. So limitations with bathing, eating, dressing yourself, getting in and out of chairs, walking, and using the toilet. And then we also looked at 2 global quality of life questions. So the SF1, looking, your general health question, as well as how you feel your health compares to other individuals your age. So in terms of statistical analyses, we use Cox proportional hazard models here. We took the time from the MHOS survey date to the date of death, and we calculated hazard ratios and 95% confidence intervals. And we tried to adjust for things that we thought could confound the association between quality of life and death, including demographics, whether you had a proxy complete the survey, how the survey was administered, so by phone or paper, the type of lung cancer, stage of disease as a measure of disease severity, receipt of surgery or radiation as reported by SEER. So again, it's not a claims-based measure of treatment, but it is documented in SEER, as well as self-reported comorbidities. So, all right, so our sample included 2,921 lung cancer survivors. The mean age was 75 years, and just over half were female. We had 20% were non-Hispanic whites, 20% were minorities, so 80% white, 55% were married or partnered, 60% were current or former smokers, which isn't surprising for a lung cancer population. And there was a relatively high burden of comorbidities such as hypertension, diabetes, and heart disease. So our key finding was that worse quality of life reported prior to cancer diagnosis was statistically significantly associated with a greater risk of death across all of the quality of life measures that we studied. And so first I'm going to show you the results from this, the global quality of life question. So if you look at the top figure, this is self-reported health status, just an overall SF1. And you can see that individuals that report poor overall health versus excellent have a 60% increase of risk of death. Fair versus excellent brings it down to about a 50% increase. And even reporting good versus excellent increase your risk of death by about 30%. And these are adjusted for the demographics that I mentioned in the previous slide. When you compare your health to others, your age, we saw a similar relationship, although the effects were attenuated a bit. So poor versus excellent is around 35%, and then it goes down as your health compared to others improves. For the activities of daily living, we saw very strong associations here. So inability to perform any of the ADLs was associated with large increases in the risk of death. So on the x-axis, these are the adjusted hazard ratios. And then you can see that for each of the different ADLs, reporting that you have trouble doing these compared to not having any trouble really increase your risk of death. So our conclusions are that pre-diagnosis quality of life is prognostic for overall survival, and this association was observed across the 10 SF36 measures, so across all of the domains, the 2 single item quality of life questions, and the 6 ADLs. And these findings are really consistent with previous work that had looked at post-diagnosis quality of life to predict survival. So in terms of strengths and limitations, Roxanne hit on these a little bit. So limitations are, generalizability. This is a Medicare Advantage cohort. We didn't have any chemotherapy data. We couldn't determine the cause of death. And then this is a nuance, but a different version of the SF36 was used between 1998 and 2005. And then the VR12 was in 2006 through 2013. I think the strengths outweigh the limitations. So it's a population-based cohort. It includes various lung cancer subtypes, the pre-diagnosis quality of life assessments, and the ability to really look at both single item and multi-item, which allows you to get a much more comprehensive picture of overall well-being. So the takeaway messages is that quality of life is a strong predictor for overall survival among Medicare Advantage beneficiaries with lung cancer. And future studies should explore the associations between changes in quality of life before and after diagnosis and overall survival. So in terms of some tips that I have about leveraging Serum HOS as a PhD student or a postdoc, this unique ability to examine patient-reported outcomes before and after cancer diagnosis is really important to hit on. So if you're getting quality of life for cancer patients, it's once they've been diagnosed and they're introduced into the cancer system, then their quality of life may be captured before treatment. But to my knowledge, very few data sets would have this pre-diagnosis quality of life, which lets you see what life was like before they were introduced into the cancer care system. Serum HOS has a variety of PROs, which, I walked you through the study. It really allows you to look both at the physical and the functional and the mental well-being, which is also very important. There's longitudinal follow-up since the survey is delivered 2 years later as well. You're able to study Medicare Advantage beneficiaries, which, usually you think about SEER data being linked to Medicare fee-for-service claims, and the Medicare Advantage population is quite different. And so this allows you to take a different look. As well as the non-cancer control group. I think that it's a really strong design to be able to, compare to the general population that does not have cancer. So also strategically, as a PhD student, I was told that it was a good idea to kind of set my future papers up. And so if you notice in the conclusion slide, I told you that, a next step could be to look at this pre and post and how that varies over time. And so that's actually what we did in the next paper. So we used the first paper to set up what the gap was that we wanted to answer in the second paper, using the same data set. And, so there were no really additional resources. We didn't have to buy new data. The same team working together. And I think that's something terrific that you can do with this data set and get a lot of different papers out in a specific area that you're interested in. So whether you're going to use that for a dissertation or if it's going to be, just publications for your CV so that you are better positioned for a job later, I think it's a nice way to use this data source to your advantage when you're earlier in your career. So thank you so much for your time, and I'm happy to take any questions during the panel discussion.
All right, so I'll take the wheel next. And my name is Tanya Wilds. I am a hematologist, oncologist, and geriatrician. And I utilize the SEER MHOS data to use an approach to operationalizing the heterogeneity of aging by creating a frailty index. So by way of background, the cancer that I treat and primarily study is a blood cancer called multiple myeloma. And you could consider it a rare common cancer or a common rare cancer. And so sample size in this cohort will be one of the things that we'll talk about that informed some of the decisions we made in moving forward with this, this project. Multiple myeloma is a cancer of blood cells called plasma cells, which I think are so beautiful. I made a quilt of it out of them. And it's a disease of aging. The average age at diagnosis in the United States is about 70. And as we've all seen and people in our lives or clinically, aging is a very heterogeneous process, with some people well into their 80s remaining extremely fit and active, and others declining in their level of function, in their energy level, and so forth. Frailty is a term that's used in geriatrics and gerontology to describe this increased risk of vulnerability to stressors in one's life. And it kind of encompasses the idea that some older individuals are going to be less resilient to new things that happen, cancer diagnoses, side effects of treatment, and so forth. But for as intuitive as that definition is, it's actually relatively hard to come up with a consensus definition. And by the last systematic review that I saw, there's 70 some definitions in the literature trying to operationalize frailty. One of the most commonly used approaches to operationalizing frailty as a clinical construct is the accumulation of deficits approach, which was developed and validated by Ken Rockwood and colleagues. And the overall approach to the deficits accumulation approach to frailty is that the total number, out of the total number of things that might be wrong with an individual, how many are? So what that you do is you take the total number of data points you have on an individual and see how many of them the patient has deficits in, total them up, and then divide by the denominator. And what's really interesting about this approach is that it's actually very resilient to whatever form of data you have at hand. It was initially developed using comprehensive geriatric assessment data, which might be gleaned by a multidisciplinary panel clinically, but it can also be applied to different data sets and so forth. The score is between 0 and 1, and the only kind of rules for what data points you choose are that they have to be aging associated, they can't saturate too early, meaning that if everyone develops that deficit, so for example, needing bifocals, as I do now, that's not going to be as helpful within the index. And it tends to work better when there's more items about function. So what we did is we looked at the variables that were available in the MHOS data set and said, which of them meet these type of criteria that had been laid out by Rockwood and colleagues? And we selected those that were appropriate for inclusion within the index, including things like functional items, comorbidities, psychosocial health, and so forth. If the patient didn't answered that they did not have that difficulty, those were obviously a 0. If they had that difficulty, it was a 1. And for those that there was an intermediate level as an option, those would receive a 0.5. When we selected this cohort, we were choosing patients with myeloma. And as has been reviewed here, the timing of the survey is not necessarily coincidental with the timing of the diagnosis. And so the investigator needs to make decisions about what the timing of the diagnosis relative to the survey makes sense. Since we were wanting to use this frailty concept close to the time of diagnosis, we wanted to find the intersection between close enough to the diagnosis that it could be seen to reflect their baseline level of health, but not narrow it so tight that we had few patients in our cohort. What we ultimately decided on for this study was completion of the survey within 1 year of diagnosis. Then we wanted to look at the association between this frailty index and survival, defined as the time from the survey until death. So prior to applying this frailty index in the myeloma cohort, we actually started with the available non-cancer cohort as a control group. We identified those individuals over the age of 65 and calculated their deficits accumulation frailty index. Then, in order to categorize the patients as either frail or non-frail, we looked at the median frailty index at each age group and used that as the cutoff for frail versus non-frail. We'll show those results in the next slide. Subsequently, we applied this frailty index that we had developed in the myeloma cohort, selecting those patients who were over the age of 65 who had completed the MHOS survey within a year of their diagnosis. And then we used the healthy controls to define whether the patient was frail or non-frail relative to non-cancer patients their same age. So the non-cancer cohort had over 2.5 million patients in it. And the mean frailty index, that integer between 0 and 1, increased over the age span, as you can see here. Those individuals whose score was above the mean were considered to be frail, and those below were considered to be non-frail. When we then turned to the myeloma cohort, there were initially 1,200 patients who had the diagnosis of myeloma and had completed a survey, but when we restricted it to those whose survey had been completed within a year of their diagnosis, our cohort was 305 patients. The average age in our myeloma cohort was 76. And what we found was that with increasing age, contrary to the general non-cancer cohort, there was actually a decreasing prevalence of frailty with age. And that's an important consideration because this demonstrates one of the important components of this data set, that the Medicare Advantage population is indeed a select population. And because of the way that Medicare Advantage is a capitated rather than fee-for-service, it's going to some degree select for a slightly more healthy or fit or robust population than a traditional Medicare fee-for-service. Now, the way we categorize patients as fit or non-fit relative to the non-cancer cohort is one approach. Other approaches have actually just categorized patients based on exactly what their number was of their frailty index, with those with a frailty index between 0 and 0.2 being considered robust or non-frail, those with an intermediate frailty index being considered pre-frail, and those above 0.35 being considered frail. And this is just pointing out, as I mentioned with the last slide, that the oldest age group in this data set of our myeloma patients tended to actually have a lower prevalence of frailty, speaking to the generalizability that this is a select population who are within the Medicare Advantage plan. So then we turned from the frailty index and looked at the survival in this cohort. And what we found is that the myeloma patients who were categorized as frail had a statistically significantly shorter overall survival, with a median of only 26 months of survival versus almost 4 years in the non-frail population. And on multivariate analysis controlling for age, sex, and race, we demonstrated that frailty was statistically significantly and independently associated with poorer survival in our cohort. This approach has been subsequently applied in other malignancies. This team from my previous institution had seen the prior work and were interested in using it, and then realized we'd been operating in separate silos and contacted me about using the frailty index in a gynecologic malignancy population, and indeed demonstrated that it had similarly was prognostic in their population. The next paper I was going to show you with was a slightly different trial design. We using the same cohort of patients. As Dr. Pinheiro pointed out, more than one study can easily come from using this data set with slightly different design considerations. In this study, I wanted to pursue a clinical question that I saw in my clinic week after week, which is that my older patients with myeloma were falling. And they weren't necessarily the patients I would have anticipated would be falling. And so my first question was, are patients who have been treated with myeloma for some period of time at greater risk of falling than they were prior to their diagnosis and relative to non-cancer patients? Now for this, ideally, we could have looked at patients who'd had longitudinal assessment of falls on serial surveys and looked at those who reported falls at baseline versus subsequently. However, because this is such a small population, with it being a rare common cancer or a common rare cancer, we knew that to find that subset who had completed the survey at more than one time point was going to yield a relatively small sample size. So instead, what we opted to do was to consider this a cross-sectional study looking at 3 different cohorts of patients. The first was those who had completed the survey within 1 year of their cancer diagnosis, so their report of falls representing a baseline. Then we looked at those who had completed the survey more than 1 year after diagnosis, and then lastly, the non-cancer controls. What we found was that there was a statistically significant greater incidence of falls in the patients who were more than 1 year out from their myeloma diagnosis relative to controls. And this ultimately, while in this CRMHOS data set, I couldn't look at things that were very important to me clinically, things like their IV chemotherapy. I ultimately was able to take this data and then move on to the Serum Medicare data and look at the use of bortezomib as a risk factor for falls in the year after their cancer diagnosis. And Kelly Schoenbeck, as one of my mentees, and I then proceeded to demonstrate that that particular treatment that causes neuropathy was indeed associated with an increased risk of falls in the myeloma population. So this is just another example of how you can take a clinical question, answer it in part, and then potentially use that to leverage onto subsequent questions that you can answer in additional data sets. So as far as the tips that I learned through this process, certainly the time frame of the diagnosis relative to when the patient took the survey is a very important consideration, and finding that intersection of not too broad of a window that it's not really capturing what's going on clinically with the patient relative to their diagnosis time versus restricting the sample size too greatly. And, you know, for those limitations, just recognizing them, acknowledging them, and really emphasizing the strengths of this unique data set, which, as Dr. Jensen mentioned earlier, is such a unique and robust and large sample of patient-reported outcomes, is such a strength relative to those limitations of the weakness. So thank you for your time.
Okay, I'll go ahead and pick it up now. So my name is Erin Kent, and I'm an associate professor in health policy and management at the University of North Carolina at Chapel Hill. And I'm going to be talking to you about Part D data linked with Serum HOS. So let me get back to the right slide. Okay. Okay, so as measurement precision, data collection, flexibility have increased, PROs have been, or patient-reported outcomes, have become increasingly recognized as key quality metrics for assessing care delivery patterns. And that would also include prescription drug use. And just like you've seen in the past presentations, there have been now large-scale national efforts to capture PROs. And this has been recognized not only by NIH, but also by FDA and CMS. And these large-scale national efforts to capture PROs, such as the HOS survey, which you can see there on the right, have enabled both a large aggregation of patient outcomes and experience. And with respect to prescription drug use, these efforts have enabled surveillance of both health outcomes and risk factors relevant to American adults, including outcomes such as polypharmacy. So for those who are not familiar with the Medicare Part D program, it was implemented in January 1st, 2006. And I know that was a question in our question Q&A. So 2006 is when it was implemented. Data that are available really began becoming available in about 2007. And the Medicare Part D data are available for both Medicare Advantage and fee-for-prescription Medicare enrollees. Enrollment has increased to 77% in 2021, representing about 48 million people in Medicare that are currently enrolled in Part D. About half are in Medicare Advantage prescription drug plans and about half in standalone prescription drug plans. And given availability for both MA as well as fee-for-service, the ability to link Part D to other data sources, including the HOS survey and the SEER Cancer Registry, is now possible. And Part D covers several medications important for patients with cancer, including oral chemotherapy, supportive care medications, and other medications used to manage chronic and acute illness. And so the SEER MHOS Part D linkage offers a unique three-way linkage between Medicare Part D, the MHOS, and SEER to enable studies of the associations of patterns of medication use with PROs. And some areas of interest broadly include medication management, medication utilization, polypharmacy, or use of multiple prescription drugs, usually at some threshold above, say, 4 or 5 drugs, and drug-drug interactions among users. So I'll touch on this briefly as a recap since Dr. Jensen presented this earlier, but the SEER MHOS brings together records of individuals in both the SEER and HOS datasets, plus additional HOS survey data in non-SEER regions. The newer SEER MHOS Part D linkage offers this ability to enable patterns of care studies of prescription medication use with PROs. Note that only SEER MHOS data linked Part D are available, so just the SEER MHOS with Part D. Here are some of the variables available from Part D, just to give you a sense of what kind of data you get when you have the Part D data available to you. So these variables enable researchers to calculate the use of particular drugs, particular dispensations and dispensations and dosages, as well as other relevant medication variables and calculations. So some methodological considerations for using this Part D data include defining medication use. So perhaps making sure that there's evidence of a 30-day supply as of a particular index date, and that index date could be survey date, date of diagnosis, perhaps some other milestone date. Using some variable number of prescriptions prior to the index date. So in some studies use just having one claim, other studies require having more than one claim. And this is partly why sensitivity analyses are recommended. Thinking about defining medication classes based on, for example, indication, use patterns, clinical guidelines, which are also very recommended. So use of criteria from, for example, BEERS, or say ASCO and NCCN cancer treatment guidelines. And then importantly, we recommend using, integrating in the project clinical expertise. So having clinicians on the study team to review whichever medications are included. Other methodological considerations include the use of PROs. So what is the role of the PRO in the research question? Is it a predictor, for example, driving an outcome? We saw that in the presentation from Dr. Pinero, where she looked at the associations of health-related quality of life and survival. In this case, for using the prescription drug data, it could be something like, do depressive symptoms help drive antidepressant use? Is it an outcome? So for example, what are the effects of medication use? Dr. Wilds presented her falls paper. So thinking about, for example, what is the role of polypharmacy in falls? Or could it be a covariate, a modifier of an association with use? So looking, for example, at pain interference, modifying rates of opioid prescription in cancer versus individuals without cancer. So I'll now present just very briefly 2 papers that were led by Dr. Amy Davidoff. as part of a demonstration project while she was at Yale before she came to the NCI that helped provide some empirical findings and also establish a proof of concept and some guidance about using the Part D data along with Serum HOS. So the objective of the first study was to examine associations between prescription pain medication receipt and PRO pain interference. So pain interference is reported on the survey in older adults both with and without cancer. So this first study was a comparison of individuals with and without cancer in the Serum HOS. And just to give you a sense of sample sizes, now these will likely change following this current linkage, but essentially the study started out with about 48,000 or 49,000 individuals in the cancer sample and about 11,000 in the non-cancer sample. When we applied SEER restrictions, those numbers dropped. Again, we looked at whether or not the first survey was within 5 years of cancer diagnosis. And just a reminder to everyone out there, the survey is not designed around cancer diagnosis. It's an opportunistic linkage. And so being really careful about selecting dates in the design of the study is really important. And you can see how that really dropped the sample. Wanting to require all of the participants in the study to have continuous Part D coverage to ensure that all the medications, all the prescription medications were captured. So this was a 1 year plus and minus the survey date for both populations. And then looking at, restricting the sample to those who had non-missing observations for all covariates yielded an analytic sample of about 15,624. Okay, so this rendered a breakdown of 9,105 older adults with cancer versus 6,519 without cancer. And some of the findings were that the prevalence of severe pain interference as reported by the survey in cancer patients was about 23% and non-cancer 20%. And then among those reporting that severe pain interference, those with any pain medication broke down to about 39% in individuals with cancer and 37% non-cancer when we restricted it to just opioids. Slightly higher rates of opioid use in cancer patients versus non-cancer patients at 26 versus 24%. The second study that our team led, and this is led by Dr. Carolyn Presley, looked just within cancer survivors. So we looked at examining associations between participant characteristics, patient-reported functional limitations due to pain, and emotional distress, and then subsequent medication use. So this was a drill down into the cancer-only sample. So we had that 9,105 sample size. We looked at moderate to severe functional limitations due to pain, that was about 69%, due to emotional distress, 48%, and then due to the co-occurrence of both was about 10%. However, in 33% of the patients with co-occurring pain and distress symptoms, they did not receive prescription medication for either condition. And in addition, the factors that were associated with higher risk of both severe pain and emotional distress were older age, those with lower educational attainment, those who had comorbidities, including coronary artery disease, stroke, and pulmonary disease. Patients with lung cancer reported higher pain than, higher risk of both severe pain and emotional distress than breast cancer patients, while prostate cancer patients reported lower, and those with increasing advancing stage at diagnosis also had reported higher rates of severe pain and emotional distress. And then finally, here are the percentages of pain medication types with functional limitations in patients with functional limitations due to pain and emotional distress. So you can see the relative prevalence there, again, by that functional limitation due to pain. And then the last category due to both pain and emotional distress. I wanted to point out this paper by my colleague, Dr. Jenny Lund, which examined monthly prevalence of potentially inappropriate medication use and possible drug chemotherapy interactions in cancer patients. This was done using SEER Medicare data, and you can see that there are 3 groups listed here: stage 1 through 3 breast, stage 2 through 3 colon cancer, and stage 1 through 2 lung. And you can actually see the line demarcation is diagnosis, but you can see their monthly medication use based on claims. And I point this out because this kind of analysis could be done with the SEER MOH Part D data, but instead of using, for example, cancer patient or cancer site groups, one could actually group by PRO reports. So some lessons learned. I think it's really important when doing analyses with the Part D data linked to Serum HOS to really consider guidelines that are out there based on around the research question you're asking. So whether that be something like the Beers criteria, STOP is another kind of criteria for examining polypharmacy, and of course, as well as other guidelines out there, say from ASCO, NCCN, and other professional societies, but also the need for clinical expertise within the team to guide medication selection and categorization. There needs to be very careful attention to medication use criteria, what really qualifies as use. And again, sensitivity analyses are key. And I didn't get into this as much in the presentation, but there needs to be careful consideration of timing that goes into it. So thinking about not just Part D coverage, but how far back you might want to go from the index state in terms of looking at medication use. And or is the question looking at associations with discrete events, for example, cancer diagnosis, which you can pinpoint to the month and year, something like falls, which are asked about over the preceding 12 months, or something like more static characteristics like demographics, or time-varying PRO states like, for example, depressive symptoms. And then where possible, do you have enough sample size, and is the research question really warranting use of more than one survey for a particular participant? So my parting thoughts before we head into the question and answer time is that this is a really great resource for studies of PROs, patient experiences with care, and patterns of medication use among cancer patients. I don't have this on here, but it's really important to forefront PROs in any analysis that is using Serum HOS data, because if you are not really all that interested in PROs, you certainly can take your research question to Serum Medicare, where you might actually have a larger sample size to work with. This is a great resource for hypothesis testing, for patterns of care research, and potential intervention target identification. And I think we saw some really nice research program development from both Dr. Pinero and Dr. Wilds as they went from sort of answering one question and leading to another paper to follow on. It's important to just leave with that this is a time and resource investment, fairly heavy required to really get into the data. So it's important to work with a skilled team and consider multiple papers. I'll just acknowledge Dr. Jensen, Dr. Mitchell in the Outcomes Research Branch, also Dr. Ashley Wilder-Smith, Branch Chief of the Outcomes Research Branch for having us here today, and Dr. Davidoff for providing great input onto these slides. So thank you so much.
Great, thank you, Erin. And thank you to all our presentations. Wow, such a wide variety of designs, projects, variables. I mean, even a paper idea in there. You guys are true superstars. Let's take a time. Let's kick it off with one of the questions I see in the chat. Someone here says that they are a medical student, hopes to use the data set in future studies. And the question is, and this is a good one because we see this a lot, how broadly do you initially develop your research question? Are your questions based off of the variables in SEER-HOS? How do you formulate questions prior to searching the available data? So how do you come up with these initial ideas and scope them away to have good, meaty projects to work on?
I'll jump in first. I think for me, it's kind of an evolution starting from kind of the broad area, frailty and myeloma, and the idea that we could use this frailty index in it. And then kind of as the project evolves, weaving in what's important to me and this project can't go forward without versus what concessions can I make. So whether that's the timing of the survey and how that's going to impact sample size, in another vein, like the falls question, so my interest was in what is the prevalence of self-reported falls in this cohort that had never been reported, and what were the covariates that were of interest. And so obviously the primary outcome of falls was present, and I couldn't have moved forward had it not been there in some form as a potential outcome. There were a lot of concessions I needed to make in what factors could be associated with falls. So for example, I did not have the Part D at the time that I did that study. And so medications are a huge component of fall risk in this population. Had lots of great data on function and comorbidities and those sorts of things, but I didn't have medications. And that was okay, because I still needed to answer the question, what's the prevalence of falls, and was able to get that part started. And so the long story short answer to your question is, I think you just have to kind of figure out what is in the data set that is of interest, and what are the non-deal breaker parts that you just acknowledge are limitations of the data set and still move forward.
I totally agree with everything that Tanya said. I think you made some excellent points. I would also say, as a PhD researcher, I think it's really critical when you're coming up with these questions and designing your study to have a clinical partner, because sometimes we may not think, oh, well, this time interval or these things might be equivalent. It's okay not to have this, but your clinical partner can really give you a reality check for that. And so all of the studies that I've done in CRMHOS have had a clinical partner, someone who, talks with me about, what's the clinically relevant question? How would this inform, their understanding of their patient, their management? How would they consider that? And then there are a lot of things that they're like, well, it's okay, the data doesn't have this, but that's fine. And so, for instance, we set the quality of life before diagnosis to be in a 2-year window. And I had originally wanted it to be within 6 months, like really close to that time, so that it was even more representative. But we were losing so much sample to do that. And I remember the clinical colleague that worked on that study was like, well, for a 75-year-old, unless like something really big is happening, like 2 years, like that, it's going to give you enough of a picture of, how their general health is. And we don't expect there to be like huge swings during that time. And I wouldn't have been able to make that decision on my own. So I think it's really important for it to be a team effort.
Great points. Yeah, and I mean, I think, Erin, from your presentation, I think Part D in particular brings a whole nother area of expertise. So these are really wonderful points. Okay, I think just kind of a general question, you guys have been incredibly successful. What's one thing you know now that you wish you had known when you started working with the data resource?
I'll jump in one thing to just point out to people. Although I've known this for a while, I don't think I really appreciated it when I first started working with CRMHOS, and that's that there are eras to the surveys. So it's really important to look, and the NCI has a great website that Roxanne talked about a bit in terms of resources to get to know CRMHOS. But one of the things in that website that you can download is the data dictionary, and within the data dictionary, there's something called a map of questions, and you can actually see how there are eras of the HOS survey. So oftentimes we want to pull over several years because you want to, maximize your potential sample size. But the HOS has gone through 1.0, 2.0, 2.5, and 3.0 now. And some questions have stayed fairly consistent. So for example, if, health-related quality of life is one of the mainstays of the resource, the SF36 was used until 2006, but then it was changed into the VR12. And some previous work that NCI sponsored led to some bridging between those two quality of life measures. So you should be okay there to pool over that time period for most questions. But there are other questions that are maybe lesser well-known or studied that may have come on or come off. For example, smoking questions changed, I think, around 2003, I think. Some new questions related to stuff like IADLs, BMI have been added over time. So really important as you're designing your questions to think about the changes in the questions over time to see what you might be able to harmonize over time and what you might just have to restrict to a particular time period.
Yeah, Erin, that's a great point. I do want to point out with the new linkage, some of the newer surveys that have very in-depth race ethnicity, there's cognitive function measures, sleep disturbance. These are all going to be probably getting enough sample size in this new linkage for people to really take a look at it. And it's exciting to think of the work we could do looking at some of the health disparities issues and quality of life in these populations. So thanks for thanks for introducing that topic. Anything from our other panelists about things you kind of wish you knew from the start? Okay, not a problem. We got lots of questions here. And I will say I'm skipping over some of the more specific questions, not that they aren't wonderful. One thing I would like to point out, please, our website, we have an email address, and we have very dedicated people that will answer very specific questions about SEER, about the Medicare Health Outcome Survey, about our data set. And I encourage you all to go. You can sign up for our listserv, email us. We're really here to help you guys figure out some of these questions and see the feasibility of your studies, because it matters to us for sure. So I think here's one. So, I think one interesting contrast to some of the work is that some of it was on single cancers, and Erin, you were talking about more general work done with multiple cancers. We had a question here about if you could explain more about how non-cancer controls are selected, and are all the fields available for non-cancer controls?
So I'm happy to answer that to the best of my ability, Roxanne. You might have to jump in something. So as I understand, the non-cancer controls are residing in SEER regions, but they don't have cancer confirmed, and they completed the MHOS survey, but they wouldn't have any of of course, the cancer-specific variables because they didn't have cancer. But they would have all of the PROs and the demographics. Is that accurate?
Yes.
Okay.
Yeah, and I mean, I guess, yeah, I think some of the methods that people have been exploring, you can do some propensity score matching and other techniques, because you really want to make sure that your comparison group reflects very similarly to the cancer or cancers that are being represented in your study. So I think that's maybe where I was going with that. I don't know if others have more to add. I think it's really neat to be able to compare to non-cancer, but I think the methods do level up quite quickly.
Yeah, what I've done in the past with the non-cancer group is taking the cancer diagnosis date from the cancer patients and then assigning a pseudo diagnosis date for the non-cancer controls. And then matching on things like age and sex, sometimes race, ethnicity, comorbidities, really trying to create comparable groups. And for SEER-MHOS, the non-cancer group is rather large. And so I actually think we've done 5-to-1 matching before, like a greedy match. And so there are definitely methods to do that and to make your non-cancer group as similar as you can to your cancer group.
Great. Yeah, the non-cancer controls, when we used them, we didn't select. It was a massive, massive cohort, 2 million something surveys.
Right. Yeah, it's a very tight confidence interval. Yeah. All right. So unfortunately, our time is cut a little short. I mean, I could talk to you guys forever. I guess any parting thoughts and wisdom for people starting this out as we close out our webinar today?
I'll just say, Oh, go
sorry,
ahead. Go ahead.
I was just going to say, you know, as has been mentioned earlier, it takes a team. And if this seems daunting, there may be somebody doing outcomes research who has some of the skill set needed for this at your institution that's just outside of the silo that you live in. And maybe worth, you know, exploring if you have like an administrative data core or something like that, that you may be able to find a collaborator that isn't just in your immediate sphere who could get you started. And if you need ideas, I have like 6 billion ideas. So just find me on Twitter. I'm like, beyond the frailty index, here's what you could do with the polypharmacy. Yeah, yeah, lots of ideas.
Great. Any other thoughts from our other panelists?
Just ditto, really mind their website, really look at that information, you know, get Roxanne, I hope this is okay, but I'd say reach out to you and you know, with essentially sort of an aims page, and also look at the current projects and recent publications to also kind of spark your ideas.
Yeah, I'm just going to echo what the other two panelists said, and also, you know, it's a fantastic resource, and I think it's very approachable, and the group at NCI is fantastic to work with. I think if you are able to commit sort of the time and resources to learn the data, it really does pay off.
Wow, thanks, Laura. That's a really great summary. I couldn't have said it better myself. Thank you all so much. Have a great day.
Bye.
Bye, everyone.